So far in our drowning lessons, we've talked about who is likely to drown and some risk factors, as well as the initial pathology of drowning. So in this video, we're going to dive a little more into the rescue side and some other injuries associated with drowning, more pathophysiology, and associated treatments. So, drowning rescue. Best leave that to the professionals. The typical EMS uniform isn't really designed for swimming, and if you try and be a hero and jump in the water after someone who has drowned, you're asking for trouble. Remember, scene safety first. Once you get the patient out of the water, move on to your primary assessment. First thing to note, if the patient's not breathing, is that breathing for someone after drowning can be tricky. You have potential water in the airways, which can make it difficult to initially expand the alveoli. So those first two breaths may seem like they're ineffective. If the patient is in cardiac arrest, follow your local protocol in terms of CPR. But there's some research suggesting 5 initial breaths before starting chest compressions, due to the importance of oxygen in these patients, and that the initial respirations can be difficult to achieve during chest compressions. Either way, if you're performing CPR on a patient who is drowned, make sure you dry them before you use the defibrillator. Hypothermia is always a concern with these patients, and it's worth taking a second to remove all wet and cold clothing from the patient and try and get them to a warm environment if you can. In these cases, smaller patients are typically do better than larger or more obese patients due to these patients being able to become hypothermic quicker. A lot of first aid courses will put a lot of stress on C-spine in drowning accidents, but honestly the research says they occur in less than 0.05% of drownings. Obviously use your clinical judgment here. Look at the history of the incident. Any mechanism of injury consistent with a head injury or signs of a possible head trauma, better put a collar on. But prophylactically stabilizing C-spine is probably overkill. So we have a patient who is drowning, and we've rescued them. After making sure the ABCs are all okay, make sure to pay close attention to lung sounds. A big indicator of how sick this patient is going to be is how much water they inhaled. Inhaling water washes out the natural surfactant in our lungs, which causes alveolar collapse and damages the endothelium in the alveoli, causing fluid leakage. ARDS. A patient with any crackles should be put on O2 and monitored closely. This leakage can develop slowly, so it's good advice for patients who have drowned to be monitored closely for the next few hours. And if any pulmonary edema presents, that patient should be transported to the ED. Any hypotension found is likely due to hypoxic injuries and should resolve with oxygen. If not, then fluid resuscitation should start immediately. Keep a close eye on these guys for any signs of respiratory failure or fatigue, and be ready to have ALS intercept and intubate these patients. Continuing treatment will be keeping blood gases and oxygen levels in a normal range, controlling hypotension, and monitoring for signs of infection. Drowning patients are prone to aspiration pneumonia from both the water and from gastric contents during resuscitation.